Hello, my name is Arthi Sridhar, and I am an incoming thoracic and head and neck oncologist at UT Southwestern Medical Center in Dallas, Texas. Today, we're going to talk about our study that was presented at the World Lung Cancer Conference this past week. Just to give you a little bit about mesothelioma, it is known to be an aggressive malignancy with a poor prognosis and limited treatment options. The standard first-line therapy for a very long time was a combination of a platinum-based doublet with or without the addition of a vascular endothelial growth factor inhibitor. And there was a pretty big trial called CheckMate 743, which really established a new standard of care for patients with unresectable mesothelioma. They demonstrated in the trial a superior overall survival with a combination of nivolumab and ipilimumab when compared to chemotherapy alone. And their 2-year overall survival was about 41% in the immunotherapy arm versus 27% in the chemotherapy arm. And so based off of this phase 3 randomized control study, this regimen then became approved for the frontline management of unresectable mesothelioma. Our real-world study is designed to be a retrospective, descriptive, multicenter study with patients included from multiple cities with the aim to describe survival outcomes and immune-related adverse events of patients who are diagnosed with mesothelioma in a real-world setting. The goal was to include patients from a diverse geographic background to improve the external validity of the study. And so we were able to include 90 patients diagnosed with unresectable mesothelioma who received this combination immune checkpoint inhibition of ipilimumab and nivolumab in the frontline setting. And we had 36 patients who received the same combination after prior lines of systemic therapy, all for unresectable mesothelioma. We really wanted to index in on understanding real-world outcomes, real-world adverse events in this study group, because there really is a paucity of data regarding these patients outside of a clinical trial, given how rare the disease is. So just to give you an overview of our results, in this study, we found that the patient population that we were able to identify was very reflective of the population that is impacted by this disease. A majority of the patients in both the frontline ipilimumab and nivolumab group and the prior line group were diagnosed with epithelioid histology, which is the most common histology. A majority of the patients were diagnosed with pleural mesothelioma, followed by peritoneal mesothelioma being the second most common. And about 20 to 30% of patients in either arm had biomarker testing done by next generation sequencing, which is currently not standard of care for patients diagnosed with this disease. The progression-free survival in the frontline ipilimumab and nivolumab group was about 7.9 months. And it was 8.43 months in the group where patients had received this combination after prior lines of therapy. This was not statistically significant, and our p-value was 0.77. The results were actually similar to what was found in CheckMate 743, where the PFS of patients, or the progression-free survival of patients who received this combination upfront, was about 6.8 months. The overall survival in our frontline ipilimumab and nivolumab group was 14.8 months, and it was about 28.9 months in the prior lines group, and this was not significant statistically either, with a p-value of 0.4. The overall survival in the real world study, in this study of 14.8 months, is actually less when you compare it to the CheckMate 743 trial, where it was about 18 months. When it comes to kind of understanding how the survival difference was numerically, so much more in the prior lines group, we think that, this can be explained by a smaller sample size in the prior line group and a potential selection bias by nature of the design of this study. Our study demonstrated that 44% of patients in the frontline group experienced immune-related adverse events. And this was seen in about 56% of patients in the prior line group. And grade 3 or 4 immune-related adverse events were noted in about 25% of the patients in the frontline group and about 40% of the patients in the prior line group. Just going back again to the CheckMate 743 trial, 80% of the patients in that trial had experienced immune-related adverse events of any type, and 30% of that was grade 3 or 4. So it is interesting to note that in the real-world setting, there's a suggestion that, the immune-related adverse events incidence is lower. It's also interesting to note that patients who received immune checkpoint inhibition in the frontline setting for unresectable mesothelioma experienced lower immune-related adverse events than the prior lines group. So that is, something that we want to double click on and look further in as we progress in this study. So just to summarize, I think the study does highlight the benefits of receiving frontline dual checkpoint inhibition in terms of tolerability. It is important because patients who are diagnosed with mesothelioma are generally an older population, and weighing the risks versus benefits in terms of tolerability then becomes a very important question. When it comes to future areas of our research on this topic and next steps, we are working on expanding our sample size both in the frontline arm and the prior line arm. And we're also including a third historical control arm in this study, where we're including patients who received chemotherapy alone for unresectable mesothelioma, so patients before this trial led to FDA approvals of this dual checkpoint inhibition therapy for mesothelioma. And so with this information, we're really hoping to improve the power of the study and the validity of the study. Another kind of future steps, or the next steps that we're looking at is biomarker testing. It's not currently standard of care for patients with mesothelioma, unlike other thoracic malignancies. And there is ongoing research to identify predictive and prognostic markers of response for mesothelioma, and that's something that we're looking into. This is an area of research that's really needed to improve the lives of patients diagnosed with this disease. Because, we're moving towards an era of precision oncology. There is also ongoing research in identifying novel therapeutic target combinations and clinical trials combining, different therapies with immune checkpoint inhibitors. When we saw some of that during WCLC this past week, such as the Pamela study, the Flora study, etc. So this is very exciting for us as physicians and for our patients diagnosed with mesothelioma. There were several real-world studies that were presented regarding this, but none of them had compared frontline to prior line in terms of outcomes for Ipi/Nivo. So I thought that was pretty unique, because the truth is that even though it is frontline, not everybody chooses to give it to patients right up front. People sometimes want to keep it in their back pocket, try chemotherapy first, or if a patient has a large burden of disease, that's another example where physicians may try to give patients chemotherapy first. So I think it's important to understand the nuances and the differences and outcomes between patients in these two settings, because that is what real world is. It's what people do, despite there being other data and options.